All right. Good morning, good afternoon, and good evening. My name is Julia Turnbull, and I'm the Assistant Director for Student Programs at the Legatum Center for Development and Entrepreneurship at MIT. Thank you for joining us for today's Inclusive Innovation Exchange conversation, in which residents and the Legatum Center are highlighting the role of data and technology in creating better healthcare access in emerging markets. Before we begin, I would like to tell you about the Legatum Center. The Legatum Center was founded on the belief that entrepreneurship drives social and economic progress in emerging markets. Our mission is to support entrepreneurial leaders who are using technology and business model innovations to create more inclusive systems and prosperity for all. I would also like to introduce our moderators for this session. Deb Gordon, who will be our lead moderator, is author of the Healthcare Consumers Manifesto and an experienced healthcare executive. She's also an Eisenhower Fellow. She will be supported by Chantal Akinyemi, who is the Inclusive Innovation Exchange Platform Manager from Resonance. All right, Deb, I'll hand it over to you.
Thank you so much. Hello, everyone. As Julia said, I'm Deb Gordon. I'm so happy to be here. You're tuning in to the 6th episode of Inclusive Innovation Exchange, where we discuss what lessons global entrepreneurs can learn from innovations in emerging markets to create more resilient and inclusive systems. You're joining us for an Innovator Watch discussion featuring Caitlin Dokart of Rescue.co, Mohammed Aburawi of Spitar, and Sergio Medina of Rise. And if I read you their bios and their accolades, that's it, we'd be done. So I invite you to follow the links in the registration page to learn more about them and join us as you get to know them over the next hour. Hi, everyone. For those of you who haven't tuned in yet to one of these, the Inclusive Innovation Exchange is a collaborative thought leadership platform to explore successes, opportunities, and lessons learned by pioneers to inform current and future ventures. Our goal is to inspire and connect people and organizations using innovation to maximize impact and promote sustainability in emerging markets. And we define inclusive innovation as local first, human-centered, and grounded in partnerships. We'll publish interview recordings, summaries, and additional content to the website linked in the chat.
And during all of our conversations in this series, we strongly encourage questions from the audience. So if you have any questions that you'd like to ask to our amazing panelists, please use the Q&A function on your Zoom screen, and I'll be back at the end of the discussion to field some of your questions.
Thanks, Chantal. Hello, panelists. Good morning, good evening from wherever you are. Thank you for joining us.
Absolutely. Happy to be here.
Thank you so much. Likewise.
Nice to be here.
So I want to kick us off with a question. Let's set the stage. Our theme today is access, and each of you has built a venture that addresses the challenge of access to healthcare or related services from a unique perspective. And I think under extraordinary constraints, especially in some cases, but I think all of you have faced extraordinary challenges in your setting. So can you describe how you uncovered the specific access challenge in your market and built a solution based on the opportunity you saw? Why don't we start with Caitlin, and then we'll go to Mohammed and then to Sergio.
Thank you, Deb. Hi, everyone. I'm calling in from Nairobi, Kenya. And so when we started the company, we actually focused on what resources did exist. I think that oftentimes when you look at emerging markets like Kenya or really across sub-Saharan Africa, the conversation is always around the lack of. So the lack of, physicians, the lack of nurses, the lack of this, the lack of that. And so what we wanted to do is we wanted to turn that question on its head and say, well, what resources do exist and how do we maximize those resources? And so the particular area we decided to focus on was emergency care. And the reason for that was that there are available hospitals, there are available ambulances, but there wasn't actually a system that brought it together. So unlike 911 in the US or 999 in the UK, there wasn't a similar system that patients could access. And so what that meant was, while there were resources that could be leveraged at a point of an emergency. Oftentimes it was so discoordinated or uncoordinated, sorry, that you couldn't access it. So I guess that's the kind of approach that we took, was rather than focusing on what didn't exist, we focused on what did exist and really built from that to create, the 911 of Kenya, and hopefully now expanding across the continent.
That's great. We'll certainly get more into your model and how you've done it, but let's go to Mohammed now.
Yeah, thanks, Deb. And just building off what Caitlin just mentioned, definitely, I think it starts with assessing the resources that you have locally. And for me, starting with Spital in Libya, it was quite anecdotal, because I was a physician who was born, raised, and went to medical school in Libya, and then sought specialized training abroad when I came to the US. And it was a path that many of my colleagues were going towards. That became even more prominent after the 2011 war. And it was a similar theme we saw across the continent. There was a medical brain drain, and we wanted to kind of look into how can technology reverse that? How can we connect doctors in the diaspora who are well equipped in understanding not only the medical experience, but also the local context back in their own countries. So when we built Hospital, that was kind of the goal, to connect doctors abroad to their home countries and patients there. We looked at the broader problem of about $2 billion lost across the African continent because of medical brain drain, with countries such as South Africa being the hardest hit. These developing countries were effectively training doctors for Western countries. But also, once we started deploying the technology in Libya, we looked at the heterogeneity, which also exists, for example, in the US, where you find doctors more clustered in areas of relative security and prosperity. Security being a huge element in Libya. So how can we look at technology and telemedicine, kind of redistribute the pre-existing resources and make sure to build a structure that will help with future allocation, provide the data for insights. So that's kind of how we went about kind of looking at the problem and approaching the solution.
Thank you. Again, there's so much more we'll get into. Sergio, go ahead. Tell us about what you saw and what you did about it.
Yeah, thanks, Deb. And thanks to my colleagues and everyone for being on the call. So my venture, RISE, has been focused on services for refugees in camps, mostly on children and education. And for those who haven't been in a refugee camp run by the UN, it is a complete lack of infrastructure, and access is extremely limited access to so much. So barely, really inconsistent electricity, water has to be shipped in. There are cell towers, but there's so little income in the community that you have to buy minutes to get data. So there's this, it's in many ways a no man's land, and extreme suffering. So we deployed and we were building a education tracker, attendance tracker for schools there. And so when we going in, we thought, wow, we're going to see the same thing. We're going to see absolutely nothing. And we discovered, in sort of with eyes wide open, that at the schools, in fact, there were a lot of services being offered, as much as they could as possible. Children from the entire community in the refugee camp would go to school and get food and get support and get, if someone was sick, the teachers and other students would try to get them some care and support. So what we found is that in this complete zone of no access, there was a sort of a gathering, a sheltering tree, and that was the school. And so that was a wonderful entry point to say, how can we, like Caitlin was saying, think about what resources are there, try to look for them, and then we focused our efforts on building programs at school sites.
When I think about the contexts that you all are operating in, it's amazing, the idea of, standing up a venture in, refugee camps or a conflict zone, or, with just so little infrastructure. So I just think there's, I'm eager to dig into sort of how you work with that. But I want to shift a little bit to this question of consumers, and a topic very near and dear to my heart and central in digital health innovation. So I'm going to start with Mohammed, and then we'll go to Caitlin. Sergio, I think that your context is a little bit different for this question, but my question for you is that your business models, each depend on healthcare consumers as customers. Now, for Mohammed and Caitlin, that's a literally paying customer. And so, Sergio, how does a consumer of your tool work in a refugee camp or a setting like that? So let me start with Mohammed and move to Caitlin, then we'll come to Sergio. So tell us about insights you gained that led you to sort of focusing on the consumer as customer. And this is my my pet topic, like how would you apply, or how could folks apply those lessons not only in emerging markets but even in the US?
Yeah, thanks. A great question, Deb. And I believe we talked about this in a separate conversation, I think last year. I think there was so much disruption that we had to do at the level of the technology, introducing telemedicine, the concept, what the technology can do, what not. However, the whole kind of part of turning users to the actual patients to consumers, that was something that was already there, interestingly. I know that was kind of a new trend in more kind of Western societies, how to empower the patient, how to make sure the patient is making the decisions rather than the insurance companies. In Libya, it was always out of pocket. There was kind of a socialized system where the government would supposedly pay for some of the service. However, some of these service, or most of them, were kind of low quality just because of pure market dynamics. And most people would have to pay out of pocket, and you'll find families kind of budgeting money for kind of rainy days and when they needed to do a surgery or take a loved one abroad for care. So there was already kind of power with the patients, in our case, the consumers or the customers, that we didn't have to kind of play around much. And that kind of made, in a unique way, made our job easier when it comes to kind of adoption, because we didn't have to kind of explain it to a third party for them to bring on their patients. As long as the technology appealed to patients, we were good to go. And interestingly enough, we see that across the kind of the MENA region and North Africa, where that is a similar trend, where you have kind of out-of-pocket drive as opposed to kind of a global insurance system.
Thank you. Caitlin, how about you? Tell us about the consumer as customer in your model and what we can learn from it.
Yeah, I mean, I think very similar to Mohammed, in Kenya, 2% of the population has insurance. So the majority of healthcare is delivered from out-of-pocket expenditure. I think, though, a few interesting things about our consumer that we kind of quickly picked up on is beyond just kind of, I guess, the business model, which I'll talk through. But I guess one is that, emergencies don't know demographic divides. Is that, emergencies happen to the rich, they happen to the poor, they happen to people who live in cities, they happen to people who live, in remote villages. And so I think for us, very early on, we recognized that our solution had to be as broad as 911, in the sense that in 911, you don't think that there's a priority line, if you have money and you kind of go to the top of the queue. And so I think early on, we kind of recognized the importance, and that really drove a lot of the decisions. And I think two important decisions that drove was, one is really meet the patient where they're at. And so in an emergency, many people think of us like an Uber for ambulances. And I would say there are components to our, technology and our
Caitlin, are you with us?
Very familiar, and Uber is exactly, the way that we operate, in the sense human. Oh, can you hear me now?
Yes. Yeah. Keep going. We want to hear what you have to say.
Okay. Yeah, I was just saying that people want to talk to a human in an emergency. They don't want to look at an app. They don't want to see the ambulance coming to them. They really need that support. And so I think for us, the way that we've built the company is a mix of human and tech. And so how do you use tech in the right way to empower, humans to deliver that care? So I think that's one thing, is that we operate very similar to 911 in the sense that we have one single number that literally everyone can access and call. So you don't have to have a smartphone. You don't have to, you don't you can be literally anyone. So I think that's number one. What we did is just made sure that it was incredibly accessible. The second was on the business model. Again, kind of going back to the fact that no one has insurance, but at the same time, out-of-pocket expenditure means that healthcare is actually really expensive and would lock the majority of individuals out. And then at the point of an emergency, you don't have time to go back and forth. You don't have time to put a payment plan together. And so what we also realized is that we had to collect revenue up front, and it had to be a subscription model such that when you had an emergency, there was nothing further that you had to do. And so that's what we've implemented and scaled actually pretty substantially, is that you pay a small, almost tax, and that ensures that when and if you have an emergency, you're always covered. And so I think that that was definitely an important kind of underpinning kind of piece of our business, was just that we had to make it, you know, access also meant affordability, and also meant you can't pay at the point of care, because that would actually limit the access.
It's so interesting because it's good for business. It's a good business model, right? To get paid up front and on a recurring basis, but it also completely improves the experience or the service quality, right? Your speed to respond is enhanced by something that also benefits your business. I'd call that a win-win. But so I think both of you, Mohammed and Caitlin, are talking about being very responsive to the market as it existed, and then, you know, understanding, meeting consumers where they are. So very market-driven solutions. Sergio, in a refugee camp, talk to me about the market or the consumer as customer. How does this concept even translate to your world?
Yeah, definitely. Well, I think it actually highlights aspect of the market that might be overlooked. So if you say consumerism and the market forces play out such that some can pay for services and some can't, so the market will then reveal those who are left out of the market. It's sort of like kind of like a meta kind of approach, but it serves a very important function of, you know, who won't be able to participate. Now, in social services, a lot of my background, we actually shifted about 15, 20 years ago to calling clients that receive services, calling them consumers. And in a lot of ways, it's kind of a shift of the model to say that, you know, they might not be paying directly for the services, but somebody is. There's a subsidy, right? And so that you would then also treat those individuals as if they were paying consumers. In a lot of ways, a human-centered design is, you know, putting that consumer of the service or the product, whether or not they pay or not, because ultimately in the market, someone will be, so it'll be the UN or the UK or the EU, USAID. And that really kind of empowers the recipient. So in refugee camps, we consider the teachers and the kids, even though they're paying nothing directly, as consumers. And then you use their voice of like, what's important to you all? What do you think that this product delivery system should be? Let's involve you in building the solution. And so when I mentioned this to you, Deb, on our call, that the most wonderful innovation that I think that we worked on is when the teachers said to us, they pulled us aside and say, hey, can you guys help us with the food distribution coordination program? And to that, it's just like, how do you say no to that? It's just complete consumer driven insight, and they innovated and they helped us innovate to support them.
So many important ideas in what you just said. And I think especially sort of elevating consumer voice as almost a form of respect, whether or not there's money changing hands. I want to pause just for a minute and encourage you all in the audience to raise your hand, ask questions in the form of the Q&A box. So we'll address questions at the end. So I'm sure this conversation is stirring up ideas and thoughts. Please share them in the Q&A, and we'll come back to that towards the end. Sergio, I want to just stick with you and ask you, you know, because all of you have common threads in your ventures of connecting stakeholders within your respective markets, how you define them. So what kind of role have partnerships played for you, Sergio? And then we'll come to Caitlin. Um, and then Mohammed. So how have partnerships helped you scale, or what role have they played in your scale?
Yeah, so I worked many years with the UN High Commissioner for Refugees, and their model really is it's a partnership baked in. So they are invited by a government to operate. They have implementing partners, and they create tripartite agreements between NGOs, the government that's hosting them, and the UN system, which is all international member states. So it's almost like you can't operate there without a partnership. It's even getting access to the camp, you have to be under their auspices. So, and I think it's great because it forces you to work with all the actors and the players. There are no lone ventures in a refugee camp, and so I think it comes with its pluses and its minuses. It forces that collaboration, but it also says, in some ways, this is how we've been doing it for 20 years. You're a startup, so you're not the big international NGOs that dominate this space, but they've been really great about carving out some space for innovation and for kind of smaller, more nimble organizations. And so it's going to take some time, but I think that they are on the innovation bandwagon and trying their best.
That's great. Caitlin, you built a 24/7 emergency response, can't fail system where there was nothing like it, nothing to build on. How did partnerships help you, or what role did partnerships play?
Yeah, thanks, Deb. I would say partners, similar to Sergio, who said like partners have always been part of the model, is same for us, is like at our core, we have built upon, others in the sense that we're a platform. And so we don't operate a single ambulance ourselves. And so what we really say is the true heroes are the ones that are, every single day responding to the emergencies that we dispatch, them for. And so we partner with hospitals, clinics, physicians, independent operations that run, a single ambulance or fleet of ambulances, and we put them on our system. And we coordinate across each and every one of them in real time to be able to then identify who's the nearest and who's best to respond. So everything that we do is based on coordination and partnerships. So it's quite an easy answer, because without partners, we would not exist as a business.
Thank you. Mohammed, I know you've built really strong and important partnerships in the Libyan ecosystem, but I also want to ask, how you're approaching expansion, beyond Libya into other parts of North Africa and the Middle East.
Yeah, so again, within the same line, I think the common thread that we see here, and it's kind of pretty obvious, that healthcare is unique in a sense that you can't really just launch an app or a new service and kind of operate in a silo. You need all these players. You need partners, both local and global, both from the regulation perspective as well as kind of funding perspective, for two things mainly. For credibility, first of all, to make sure that the people trust you with their data, with their health, with their lives, essentially. Make sure that you're a credible source. You're not just this new kind of NGO or new company that popped up and is going to kind of exploit them, or doing what you're doing for PR purposes, that you're actually backed by the governments that hopefully they trust, but also for scalability purposes. And that's kind of what we've seen in Libya. There's incredible leverage that you get as a person or an entity that's just starting, and you just kind of plug into an existing system. And even if that system doesn't exist in a means of infrastructure, for example, in Libya, we didn't have a pre-existing EMR, an electronic medical record system, and that was a huge challenge. But we had the kind of the skeleton. We had, for example, the Libyan medical syndicate with more than 10,000 physicians that kind of instantly kind of plugged into our system. We had the Libyan Authority for Medical Records and Documentation that we can just kind of access with and kind of help provide some APIs and servers and make sure that we leverage whatever data they have compiled so far. And that was important because the relationship was mutual, right? We helped them kind of broaden their reach, especially early on with the COVID crisis, but also provided data for them that helped them improve the allocation of their limited resources. And as we go beyond Libya, it's the same model that we're kind of building on. The MENA region is unique in a sense that it has this kind of common fabric, 22 Arab countries, same culture, same background, nearly 500 million in population, which is growing at an incredible rate. However, there is some pre-existing kind of networks that are helping us to kind of grow, mainly the UNDP. We have an incredible partnership that we just launched early this year with the UNDP. And now we're working with the UNDP Digital X Accelerator in Jordan to kind of replicate what Spitar is doing in other countries with similar contexts, such as Sudan, Somalia, but also in more stable nations where we can kind of provide a cross-financing structure. The people who can pay for the service will, and the people who can't don't have to. But partnership have been incredible in that sense. I don't think you can just kind of do anything in healthcare, whether it's in the contexts that we're working in, which are less resource, or even more developed contexts, without working with the regulators and the official partnerships.
Thank you. I want to move to Caitlin now and ask, we talked a bit about your Rescue.co's subscription model. And I want to ask, I guess we talked about how you got to that point and why it's so important. Question, can that model work outside of Nairobi? Is it a urban, density opportunity, or can it work in more rural areas? And, sort of same question, like, can you export that to other countries or contexts?
Yeah, that's such a interesting point in question. I think definitely something that we've really been at this last year. So we started 4 years ago and have grown substantially. I mean, we started in Nairobi, and that's where we predominantly operated. Then we went to the next, biggest city, Mombasa, on the coast. Then we went to the next one, and the next one, and the next one. And so the way that we've scaled our subscription product at first was B2B. So we sold to companies, and this could be anyone. It could be everything from Uber drivers to factory workers to schools. And we really cracked that. And so that's what has allowed us to kind of scale to the cities and towns. As it relates to getting outside, because more than half of Kenya still lives in non-urban areas, is that we have partnered, again, all about partnerships. So we partnered with NGOs, we've partnered with donors, we've partnered with the government, and we've partnered with telcos. And all of those, ultimately, pay or subscribe on behalf, of individuals in those communities. So a good example of that is during COVID. Thankfully, Kenya hasn't been hit as hard as many places in the world, but what we have had is we've had a curfew for the last 10 months. And so from the hours of 10 p.m. to 6 a.m., you can't leave your house. And so how do emergency patients, get to the hospital? So previously, oftentimes, you would walk, you would take a private vehicle. And so what we've been working on is, with the EU and a number of donors, is to make sure that women can safely get to the hospital to deliver at night. There's 2,500 babies born every single night in Kenya, which is one of my favorite stats and kind of crazy. And so, we have partnered to ensure, women in the remotest corners of the country can reach the hospital. And throughout COVID have achieved a 100% survival rate, which is pretty unbelievable. And so I think, the person who's paying for the subscription looks different in Nairobi. It might be a UN employee in Nairobi, or, the American ambassador is a rescue subscriber, whereas in, the kind of more rural areas, the person paying is just quite different. And we've really tried to adapt such that we can reach 100% of the country.
Those are some amazing statistics, and a really good example of kind of leveraging a crisis to do good for the country and your business. I have a question that both you and Sergio have raised for me, and to some extent Mohammed as well, which is when you have a corporate, or an NGO payer, so paying on behalf of the individual, how do you keep in touch with, really keep the finger on the pulse of consumer needs and, that sort of feedback from the consumer market? of Caitlin, and then I'll go to Sergio, and we can open it up to broader topics too.
Yeah, I think for us, ultimately, we're still delivering the service to the end user and the customer. And so I think that, we always have a pulse on what's happening, and I think for us, we also didn't actually partner with NGOs or, governments early on. Is only once we had an established model could we slap them in, because I think that we were actually quite concerned that they might kind of take us in a direction that was very, specific, and I think what we wanted to make sure that we had a broad enough solution that could really appeal to all. So I think it was also the right stage for us to bring on partners like that, where, we already had a platform and system in place. But at the end of the day, like, we're the ones delivering the service, we're the ones receiving all the emergency calls, we're the ones dispatching the ambulance. So we know how every single emergency response, was handled, and the outcome of it as well.
Thank you. I think that's such an important challenge that a lot of entrepreneurs face, of, where the efficient revenue comes from is often not the consumer. So how do you actually serve, give the consumer preeminence in that situation? Sergio, do you have anything to add on that? And then I have another question for you.
Yeah, I do. So the insight that I'm thinking about is that there is a humanitarian aid, international aid market of its own, and it's unique. It's different than the free market. It's a subsidy market. But I do think that, having worked with so many different international NGOs in that space, it's how can they keep the way that they keep the consumers front and center is they step aside, right? They realize that they have a mandate. It's a humanitarian aid mandate. Often it might be a human rights instrument or a humanitarian law, treatment of refugees or asylum seekers. And that is sort of the leading guidance. And, some of the most diehard people I've met that say, let's listen to the consumer, let's listen to the refugee, to the asylee. And I think what they do is they, in a lot of ways, humbly step back and say, okay, even though this is massive EU or Australian money, if the service that we're providing isn't really protecting women's rights or children's rights, then we need to adapt. We've made a mistake. And I think that there's so many similarities between the humanitarian aid marketplace, let's call it, and for-profit, market-driven, where you're both adapting to what the people you're trying to serve are saying and behaving. So some interesting intersections there.
Definitely. In that context, it's a perfect segue to my next question for you, Sergio, which is, as you have tried to bring, or worked to bring critical services to extremely vulnerable populations through technology solutions to make aid more efficient, what insights do you have about how organizations can scale solutions for administering these critical essential services, which may have application to the COVID vaccine, for example? And an add-on to the question is, what kind of funding is required to make it happen?
Yes, it's a very technical term. I call it the piggyback method. Piggyback on the big players. And when you're a small player, a small fish, you have to, until I guess eventually you're a medium or a large. So our approach was to piggyback. I was telling you the other day, my first job was at UNICEF, and so that gave me this orientation that you can actually mount a global response to child protection, and that, in some ways, it gave me this impression that, like, yes, we can do big things, but it has to be in partnership and cooperation. Like, we all, smaller ventures have something to add, definitely in terms of innovation, but what is the David Kelly from IDEO saying? He says, if you want to go fast, go alone. If you want to go far, go together. And so you need to, in our case, you need to team up with the UN system, because that is the key player in humanitarian aid. It would be foolish to think that we could go it alone. So then in terms of COVID, talk about, COVAX and the massive global international effort for billions of dollars to be poured into an operation. Now, these large operations also come with you need some turtles and you need some hares in that operation. You need sort of leads that are going to go to the field that know what's going on in different regions, and you also need the institutional funder in Brussels or in New York or in DC. So man, that talk about a complex undertaking, but one that is saying this has to happen. It's almost like our hand is being forced to deal with something and inequalities that have been there for some time. So it's a big undertaking.
Yeah, even in the best of resource environments, it's incredibly challenging. And actually, I'm curious, technology, I'm in Massachusetts, and there's been somewhat of a brouhaha over, lack of systems or lack of, if people, there's a lot of reports of people struggling to find vaccines through the state's website or what have you. I'm just curious if you have any last thoughts on sort of the role of technology could play in enabling or, easing some of that complexity.
No, absolutely. It can facilitate it quite a bit. And I think in a lot of ways, it can also reveal the spots, let's call them the gray spots, the spots that are not being reached, right? Through sort of extrapolation of where things are reaching. If you look at a broadband access map across the US, you're gonna see a lot of spots that have gray and that don't have. And so that actually is your roadmap, right? You say, oh, well, we're gonna focus on the gray spots so that they become, green. So I think that's a really, you can quickly reveal that through technology and analysis.
Thank you. Okay, I've got one more question. Audience, you get the next bunch, so make sure you're putting your questions into the Q&A box. But I'll hand the last question to Mohammed and then Caitlin. Thinking back, and then I'll watch the clock if we have a minute, and Sergio, if you have something to add, just we'll have you chime in. But Mohammed, thinking back to where you were a year ago with your venture compared to today, how have the conditions imposed by COVID accelerated or changed or impacted your venture, who you serve and how you operate?
Yeah, I think definitely with the COVID pandemic since the beginning, we have seen an incredible kind of mobilization and catalyzation of all solutions related to healthcare, right? And specifically digital solutions. And in Libya, we have been in a unique position because we're not born out of the crisis, but pre-existed. So it was just a matter of how can we reach out to the government, and the government actually reached out to us and said, hey guys, I think we need this thing called telemedicine. And when we looked right and left, you are the only ones in the kind of in the field. So how to just kind of walk us through this and how can we leverage it? So we definitely kind of experienced massive growth during kind of the early months of 2020. I think we had 600% growth month over month in the beginning, and that kind of continues now as we scale and introduce more solutions. And I think when you look at that, and I think the insight that I want to kind of drive here is it's all about rapid mobilization. I think in times of crisis, rapid mobilization is key. Whether that's kind of operating in areas, as Sergio mentioned, where you have refugees and low resource settings, but also we've seen it, for example, in New York in the midst of the COVID crisis, early 2020, where you have a country with incredible capabilities, but now you are in a situation when you need rapid mobilization of all these doctors, all these resources to an area where it's the hardest hit. And that's kind of the only way you can do that is via technology. And that's kind of where telemedicine, where, for example, the solution that Caitlin is working with emergency responses, it comes in, right? And I think it has been incredible, and the growth has been mind-blowing, to be honest. And I think digital health and digital solutions and this disruption of healthcare is here to stay. And I don't think we're going to be saying telemedicine or digital health in the future. It's just going to be how healthcare is practiced.
I love that. I bet you're right. How long will it take? We'll take bets in the Q&A. No, just kidding. Caitlin, do you have any thoughts on how your business has changed or who you're serving has evolved as a result of COVID?
Yeah, COVID has been completely unpredictable in all the ways that probably it has been in every single country. But I would say that we have grown in a completely different way. I mean, I think early on, back in March, when the first COVID case was identified in Kenya, of course, we, instantly mobilized all of our ambulances to make sure they had the right PPE, they had the right training and skills to transport patients, because we were anticipating a massive boom in requiring transport and transfers of patients from home or between hospitals, COVID related. But like, as I said earlier, thankfully, we have not had a massive outbreak in Kenya. So while we still have done, plenty of COVID transfers and taken people from their homes safely to the hospital, if they're suspected or confirmed, I think that what we've actually seen is that a result of people not going to the hospital for other reasons. So not going to the hospital for chronic care management, maybe they're diabetic and not going to the regular appointments, maybe mental health, not going again to the regular appointments, is that emergency cases just overall have increased outside of COVID. And that's oftentimes because emergency response, and you oftentimes hear about this in the US, is the ER is, used as that kind of catch-all. And that's how ambulances are used as well, is like, we are there to catch the healthcare system. And so when there is a crisis like COVID, which had, much greater economic impacts in Kenya than the health impact, is that then we saw the kind of outlay of various events that normally would have been handled by primary healthcare, but waited long enough that now we picked it up from an emergency standpoint. So I think that, we really became a much larger kind of player force and kind of a system within the country during this time, because it was so critical that we did get people to healthcare when they needed it most.
Thank you. Okay, we're at the hard stop for audience questions. So I just want to say thank you to all three of you for such incredible insights. And, just to point to the power of partnerships that you've all talked about, and the absolutely critical way partnerships have enabled your business, your local or on the ground connections and knowledge and know-how, which obviously, Sergio, is really difficult right now to be on the ground in a camp, but that sort of local knowledge, and both in enabling partnerships and also in building the scale and sort of really having a pulse on the consumer or the end user as critical. So I just, and then finally, I want to say the way you all use technology to, augment or complement the human dimension to the services you're providing, I think offer a lot of lessons and insights for others around the world, and including much more resource rich environments, I think, can learn a lot from your attention to the end user and to scaling through technology plus human intervention. So with that, I'm going to bring back Chantal and let the audience questions take over.
Thank you so much. We have a lot to still discuss, and we're going to try to squeeze it in these last 15 minutes. So thank you for all of your questions. Jumping in, kind of exactly what Deb was just talking about, we mentioned partnerships a lot during this discussion, and some of our attendees wanted to also know what other approaches you apply within all of your different contexts to help establish trust, especially with the consumer. We talked a little bit about how important building that trust is. What other approaches and tools have you guys been using? Let's start with Sergio, and then we'll go to Caitlin and Mohammed.
Yeah, so we were in Kakuma refugee camp in northern Kenya several times about a year ago, and we conducted maybe 50 interviews with children, and they were, quite honestly, I think they were terrified of us. We had a group of, there was like 6 of us, and ways that we tried to build trust with them is that we kept showing up, and you kind of go slow. You don't make it transactional. So for us, it was really kind of teaming up with the consumer themselves, spending some time with them, going and showing up, and especially with the delicate nature of working with children, establishing some sort of relationship. And I think that extends as well to adults and to partner agencies. There's this human element of ways to build trust, and there's also human elements of ways to destroy trust. So you really want to lean into that personal kind of human connection and putting people at ease. And then the design research field is actually really good at methods and ways. So I can share some resources. One organization is called Adaptive Path, in addition to IDEO, and they have a lot of resources on how to create these trusting interactions.
Oh, that's great. Caitlin, do you have anything to add?
Yeah, I love what Sergio was saying, because it's exactly kind of like our mantra. It's just consistency. But I think also just kind of showing like the kind of humility, or because early in the days, this is like 4 years ago, but I'm not a paramedic, I'm not a physician, but I would ride in the back of ambulances, and I would really try to understand and make sure that I knew everything from the ins and outs, and showing up every single day and kind of getting and gaining the trust of our ambulance teams. So I think that's one way that we did it, is really riding along right side them, so that I fully understood exactly like their challenges when they were going out and doing a life-saving rescue. On the kind of consumer patient side, it took us a while, but I think our most powerful way of building trust is through testimonial and stories. When you save someone's life from a heart attack, from a road accident, from the worst days and moments of their life, is a really incredible and powerful story, and that has been kind of our main mode of building trust, is through stories and through real individuals that we have saved and are here today to tell kind of their story and in their voice.
Yeah, absolutely. Mohammed.
Yeah, I think I would definitely emphasize what Caitlin just mentioned with humility. I think it goes a long way. I think everybody who comes into a specific setting, even if they understand the ins and out, has to kind of be humble in their approach, humble in knowing the limitation of their skills and the capacity, and even understanding of the problem. Because once you kind of come across arrogant and here, let me show you how it's done, and I have all the solutions, and you're doing it wrong, and that's when you see kind of a backlash, and that's kind of where people kind of retrieve and say, you know what, even if that works, I don't want it. And I think that's an issue that humanitarian aid organizations, especially like Sergio just mentioned, how kind of very interesting looked at as a market. That's what has been happening in the past. And we saw that in Libya, for example, where basically most of the money would go into, for example, buying food or medication and providing more hospital beds. And you'll find all these resources piled up. For example, there was a situation where we had a hospital in the south of Libya, which was more than 1,000 miles away from the capital, and was a very remote, and they had piles of medication, and it would go wasted because there was no enough doctors to kind of prescribe those medications. And one of kind of our team members sent me a picture with the main hospital kind of closed with the doors shut, and they had kind of just taped a piece of paper and said, sorry, no doctors. And I think that's kind of the misallocation of resources and unfortunate, like maybe unintentional arrogance that we see. by thinking that, you know what, we're going to just buy medications, we're going to put it there, and that's going to solve everything, and everybody's going to be happy, and they're going to have their own drugs. But and I think that's why we see more now an approach which is more towards efficiency and sustainability, especially with our work with the UNDP. That's kind of the first question they ask: how are you going to be sustainable beyond this partnership, beyond this funding that we're going to give you? And I think that's very important in establishing that trust. And I think the second thing would be just being transparent, just sharing with people that you don't know, and the feedback that you get, in our cases from the doctors, the things that they like about the solution that we're presenting and they don't like. The same thing with the patients, and just kind of learning from that feedback.
Yeah, absolutely. Our next question is for Sergio specifically. You've worked within the UN system, and so one of our participants wanted to know why you chose to go into entrepreneurship. And I know you're still working alongside UN systems, and you're still in close partnership with them, but what kind of pushed you to go outside of the system?
There's two trains of thought. So a lot of folks really want to work for the UN and work for them for life. In a lot of ways, it's extremely well funded, and you get sort of a diplomat visa, and you get really well taken care of. The system takes care of you very well. At the same time, you're often moving from country to country, and you're really remote locations. You're away from your family, and a lot of times there's unaccompanied posts where it's just shifting dynamics in terms of insecurity. So it wasn't for me to stay long term. I wanted to come back home and be with my family, and I was like, wow. But the experience of having been there and having been embedded for so long, it was such a privilege. But I also got to see, like what Mohammed was saying, there were so many instances of waste, of discoordination, miscoordination, and at the same time, there's an opportunity to make things better, right? And for someone, it's like a former humanitarian aid worker building technology for humanitarian aid workers. I felt like I could be more valuable doing that than other than being stationed in Bangui in Democratic Republic of Congo for a couple of years. I felt like I could do more and be more helpful to the system by kind of going the route that I went. But yeah, it was a difficult decision. But I'm gonna keep working with them and collaborate.
Yeah, absolutely. The partnership, I'm sure, is still very important. The next couple of questions are specifically around technology. And Caitlin, you had mentioned earlier in the conversation, kind of finding this balance between technology and human interaction. And I'm wondering if you can kind of speak a little bit more to that, of how do you find that right balance, and what is the right mix of human versus tech? And I'm sure Mohammed and Sergio will have also things to say about that, but let's start with Caitlin. And sorry, also the second part of the question is around data security, and if you can speak to how you ensure the security and privacy of your customers.
Sure. Yeah, I think that when we think about technology, especially as it relates to healthcare, it's about how do we give healthcare. So our dispatch center, we run a 911 dispatch center, and it's staffed by nurses and paramedics. So they are, medical themselves, but how do we give them the tools to do their job even better? So how do we take away anything that is actually just a distraction? And that's kind of where, we ensure that there's technology to support them. So a good example of that is, the healthcare system, in Kenya, there's emergency departments aren't equal. Some emergency departments might have an X-ray, some might have a CT scan, some might have ability to do a emergency cesarean. And so one of the things that we did is that, we digitized the entire healthcare system as related to emergency services. And so that's something that, humans shouldn't have to do during an emergency, because that's just wasting, their time, and also their focus is now being shifted to kind of problem solving something that should actually just be digitized. And so I think that we have, and I think that it's constantly something that we're looking at, is this like striking this balance to say, how do we take away anything that would be better served by technology, but how do we retain the human at the center of it, and that they're the ones kind of leveraging the technology to make all those decisions. So that's just one example, but there's a lot of things that we do to kind of try to figure out that like correct equation. And I think that that's also always changing too, as technology continues to be kind of more pervasive within healthcare. As it relates to data security, that's pretty easy. We build with today's technology. So today's technology means that, we can use things like Amazon Web Services that has a HIPAA compliant, server. And so from day one, we've been very thoughtful and really, really, put that at the center of our technology solution, is making sure that we're using kind of best in class principles. So that is actually not a challenge.
Yeah, absolutely. It's nice when things like data privacy become easy for us, right? That hasn't always been the case. So Mohammed, Sergio, do you have anything to add about that balance between human and tech interaction?
I can take a stab on it. For us, I think we definitely see the local team, the champions. We have a team of over 70 people in Libya, excluding the people who are doing the tech work. These are just kind of recent graduates and junior physicians who are helping kind of spread the word, recruit physicians, recruit patients, answer their questions. And these are the actual champions. For us, I think the solution and the technology is not very novel. I think most of the solutions already exist. Actually, I like this kind of quote, which I often share, by William Gibson, where he says, the future is already here, it's just not evenly distributed. And I think this is what we see across the world. We see kind of areas, for example, in Boston, where you have the cutting edge robotic surgery, all these incredible medications, where innovations usually start. We see it obviously with the vaccine, but then how do you get these innovations and discovery to be distributed, right? And that's kind of where technology offers that solution. And I feel that technology is going to be the element that's going to help the African continent, or in general, or just kind of areas of general who have been suffering of decades of inequality, leapfrog to the kind of future of healthcare using these technologies. And just to comment quickly on the element of data privacy, I think we're very wary of digital exploitation. And I think this is kind of a conversation that's starting to emerge about like all these startups and companies going to Africa and just kind of using patient data or healthcare or population data in general. And where does the data go? Like, where is the regulation? Especially, for example, in Libya, there's no kind of specific regulations that govern that. So it all comes to our kind of ethical code and making sure that we're, as Caitlin mentioned, employing kind of best practices and making sure that it's HIPAA compliant and so on, not so to exploit all this data that has been gathered.
Yeah, Sergio, go ahead.
Yeah, I would say, I'm sorry, I was off mute in typing, but what I would say is that, try to put the technology as a second place to what you're actually hoping and trying to achieve. You're trying to deliver healthcare, you're trying to deliver emergency care services and facilitate that. The technology is just a tool. It's not anything special or fancy, and just really always keeping it, we can get caught up in AI models and mapping and, optimization equations, but it's really second fiddle to the sort of mission of what you're trying to do. You're just using it as a way to reach your mission. And so not to get caught up in the machine learning or the AI, the capability. You can wonk out and nerd out on it, if you want, but like, let's remember, we're using technology for good, all right, to help people. And I think I'll end with that.
Yeah, no, I know that we could kind of keep going on and on about these topics, but unfortunately, that's all we have time for today. So I just want to say thank you so much to our panelists, to Deb for your really thoughtful discussions and for sharing your experiences.
Well, thank you for creating this opportunity, and thanks to our viewers for joining us. Please be sure, if you haven't already, please be sure to subscribe to the Inclusive Innovation Exchange newsletter for future webinars, resources, and the latest information on inclusive innovation and global health.